We're live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to Ortho TV online in association with Orthopedic Research and Education Foundation. To introduce today's speaker and topic, I hand over to the Secretary of OREF, Dr. Janki Badani.
Thank you so much, sir. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have spine specialist Dr. Gautam R. Prasad, who is a consultant of spine in Paras HMRI Hospital, Patna. So I am very thankful to introduce him, and he'll teach us about the fracture in vertebra in osteoporosis. So over to you, sir.
Yeah. Warm greetings of the day. I am Dr. Gautam R. Prasad, orthopedic spine surgeon. And I will be talking on osteoporotic vertebral fractures. So as we know, osteoporotic vertebral fractures is actually the incidence and the prevalence is increasing as the age, lifespan of us is increasing. And if you check out the quantum of this disease as compared to heart disease, stroke, breast cancers, the prevalence and incidence both is quite high. And generally, when the osteoporosis sets in, there is a low bone mass and microarchitectural deterioration which sets in. And because of this, the patient has got osteoporosis related issues like osteoporotic fractures, paralysis, and other things. Now, WHO has given us some criteria based on DEXA scans, and that we'll be seeing in details. But once the DEXA scan, we see the T-score, the standard deviation, if it is more than minus 2.5, then we call it as osteoporosis. The persons who are at highest risk to develop an osteoporotic fractures are the geriatric age group, ladies, the one who had got previous osteoporotic fractures, patients with low bone density, those who are on steroid treatment or with comorbidities like diabetes, Parkinson's, or very thin patients, or patients who smoke or drink. Almost 30% of these fractures, they are clinically apparent. So those which we actually see in our OPDs, they are actually 30% of the entire osteoporotic issues that that's present worldwide. And most commonly, it's the dorsolateral junction where this osteoporotic fracture in vertebrae occurs. What does it lead to? It leads to pain, which is commonly known to all of us. And with multiple osteoporotic vertebrae fractures, or with a single vertebral fracture, which has united in kyphosis, there develops a deformity. Kyphotic deformity is the most common deformity that we see. Kyphoscoliosis can also be associated. And along with this, many times they may present with neurological weakness. As a spine surgeon, the role of a spine surgeon will be not only to do it, manage it surgically, but also manage the medical part of it. So the management includes the medical part plus correction of the deformity if present, address the instability if it's there. And along with this, we have to address the neurodeficit and also keep in mind that we are dealing with not a normal vertebrae, it's osteoporotic. So we have to take due care of the implants that we are going to use and supplement with necessary biologics. Are all these vertebrae fractures, osteoporotic vertebral fractures, clinically important? Yes, they are, because even if they don't lead to significant deformity or weakness, they are associated with moderate to severe back pain and also limited activities. And in geriatric age group, when one has diabetes, blood pressure, this limited activities can lead to acceleration of other comorbidities. Now, have a look at this mortality data. If there is an osteoporotic fracture, there is an increase in mortality of seen in men as well as women. The commonly associated symptoms which we associate with vertebral fractures, osteoporotic vertebral fractures, are back pain, loss of height, deformity, reduced pulmonary functions, and diminished quality of life. And it leads to a vicious cycle. So once there is disability, one goes to the patient wants to avoid activity. So there is an inactivity phase. This leads to further osteoporosis, further weakened bones, further increase in deformity, muscular weakness, and this leads to disability. And the cycle goes on repeating. Also, one important thing that we have to know as a surgeon, that whether the screws that we are going to put in or wires which we are going to put in, how good they are going to hold it. If the bones are porotic, then the chances of screw pull out is quite high. So as the advances, with the recent advances, now we have other screws which will be talking details, like the double thread or PMA coated screws, fenestrated screws in which we can inject cement. All those things are in the market, and we'll be going through all those things. So once the patient walks into a clinic, then we have to make a diagnosis. And diagnosis is mainly based on the clinical and the radiological pictures. Blood test and other things, they are not of that much relevance in osteoporosis. I am talking about the primary osteoporosis, not primary osteoporosis. So in acute symptoms, there is back pain with difficulty in standing, walking, and there is restriction in the activity level. Clinically, once we see that there is patient may even say that my grandma is actually her height is decreasing. So this is because of the vertebral body height which decreases, or the kyphosis which sets in. This leads to decrease in height as the age progresses. And along with this, there is reduced lung volume, which can lead to breathlessness on walking, specifically on climbing stairs. Various biological parameters are mentioned, but these are more into research, and clinically we hardly do this. On X-rays, in the era of digital X-ray, one has to be very careful when one is making a diagnosis of osteoporosis, because it's all technician dependent. CT scan and MRI are very helpful in this. In MRI, once there is an osteoporotic fracture, early fractures will show as a hypointensity on T1 as well as T2. And if there is a cumulative sign, that is the fluid which collects in the osteoporotic vertebrae, then we'll appreciate a hyperintensity on T2 image. That is a cumulative sign that we appreciate. Also, along with this, one should not shy enough to do shy from doing dynamic X-rays. By dynamic X-rays, I mean X-rays done in flexion extension, also the lateral views done in lying and supine position, because many times this demonstrate increase in kyphosis at the segment and regional level when the spine is loaded. So dynamic X-rays is very important, specifically once if planning a surgical management, whether it is vertebroplasty or correction of the deformity, one should always do a dynamic X-ray. Another modality for diagnosis is DEXA. It's like an X-ray, but it has been the study has been done on there are basically two scores that we see. One is a T score and the Z score. In T score, the what is actually seen is what will be the density of the bone of a normal person in comparison to the patient. And who are these normal person? The normal person, there is a data study done of all the individuals, of the ladies specifically, of 30-year-old, and that's why that counts as T from 30. So third decade, basically, from 21 to 30 years. So the T score of an individual is compared with that of the that particular country and or that particular race, and that's how we get the T score. And based on that, if the patients, and we calculate what's the standard deviation. So if the T-score is -1 standard deviation, more than that, then it's normal. If it's between -1 standard deviation and -2.5 standard deviation, it's called as osteopenia. And if it is between -2.5 less than -2.5 standard deviation, then it is called as osteoporosis. In severe osteoporosis, it is between -2 standard deviation to -4 standard deviation. Now Z-score, especially in pediatric age group, we give more importance to Z-score, and is Z-score of -2 or lower is defined as below the expected range of age, and a T-score of above -2 is within the expected range for that particular age. Now, there's also one more parameter to assess and predict the chances of having an osteoporotic fracture. Now, this is called as a FRAX score. In this, it's a score which is calculated online. One has to fill in the data, all this data like age, weight, height, sex, whether the person smokes, any history of fracture, parental history of fractures, any comorbidities like rheumatoid arthritis, steroid intakes, or any secondary osteoporosis, whether the patient is an alcoholic, and what's the BMD. Based on all these things for that particular country, there is all this facts has been calculated already, and with this, at the end of the thing, the software will let you know what is the risk of the person of having any fracture because of osteoporosis over the next 10 years. Now, once we made a diagnosis and we also know whether it's a fragility fracture, what's the expected percentage of having fracture in future, then comes a part of treatment. And treatment is always given for those people who have a BMD studies. If the BMD is not very significant, but still the patient has got a previous history of osteoporotic fracture, then still we need to start the treatment. Now, always remember, though clinically and radiologically we feel it is osteoporotic fracture, always be very cautious and rule out that the other problems like metastasis, tuberculosis, myeloma, malignant tumors, they are not fooling you. So all these cases, one should always do biopsy. Even if we are doing a vertebroplasty, we see to it, we send the sample. First, we take a sample and send it for histopathology, and then we inject the cement. So that's the routine thing that we are following. Now, prevention of osteoporosis. To prevent that, one should actually focus on the lifestyle. The more we are living an active health lifestyle, the better it is. Alcohol and smoking should be stopped as much as possible, or the quantity should be decreased as much as possible. A healthy diet which has good amount of calcium, vitamin D, and protein. This is necessary for building a good bone stock. And in geriatric age group or patients who have got Parkinson's, one should see to it that always being accompanied, the corridors are well lit, even their floors in the bathrooms and all, they have some supports, sidebars, so that the chances of patient falling is minimized, and then the chances of having osteoporotic fracture also minimizes. Now, coming to medical part, drugs. Now, drugs we can classify into anti-resorptive agents like calcitonin, hormone replacement therapy, and selective estrogen receptor medications. The other modulators are the ones which act on osteoclast and the one which acts on osteoblast. So, bisphosphonate, these are the one which acts on osteoclast and there are oral as well as injectable forms like the alendronate and zoldronic acid is the injectables. Other anabolic steroids or estrogen receptor modulators, though their role is bit high, whether they actually help in building up the bone stock. Now, traditional management, when the patient comes in, we have to see to that the pain is taken care of, patient will be on bed rest, physical therapy in the form of exercises should be started, and only in selective cases, one has to consider surgical intervention. Now, surgical intervention might vary from a smaller thing like a pain block to a procedure like a vertebroplasty or kyphoplasty, which can be done on a OPD basis, to surgery. Now, in surgery, depending on what the patient has got and how badly the patient is disabled, one has to take a call. Now, coming to vertebroplasty, in this patient, many times, whenever we do it's a dictum that we follow. Whenever we do a vertebroplasty, we see to it that first and foremost, when the needle goes in, you take a sample out, send it for histopathology, and then you do the vertebroplasty. Now, in this, it can be done by a trained spine surgeon or an orthopedic surgeon, or even radiologists are now doing it. Now, vertebroplasty is mainly for painful osteoporotic fractures, which have failed with conservative management. Even in metastasis patients, we can do this vertebroplasty, and before doing that, one has to do a CT and MR just to confirm that there is no end plate is intact and there's no chances of leakage of the cement. Once we are sure of that, then by Perkin's method, we actually put in the Jamshedi needle, check it on C-arm on AP as well as lateral view. You have to first confirm with the injections dye, see to it that it doesn't leak. If it leaks, then we can plug the leak with the help of gel foam and again try with the dye. If the dye doesn't leak, then you inject the cement. Another procedure in this lane, in the same category, is kyphoplasty. Now, the difference in kyphoplasty is we actually recreate the vertebral height, and that is done with the help of balloon. The main important factor by this is you create the height of the vertebrae, the lost height is regained, and also when the balloon is inflated, it also causes collapse of the not collapse, it aggregates the surrounding cancellous bones. So chances of leakage of the cement decreases significantly. As you may appreciate in this film, this height of the vertebra has been restored and the normal alignment is achieved. So it improves the quality of life, reduces the pain, and restores the vertebral height. So even the deformity can be taken care of. However, there are times in which before we do this, we have to check out with the X-rays, dynamic X-ray, and confirm that the pathology, the kyphosis which has developed, is only at the segment. It's not in the entire regional or global kyphosis, global instability. So if the instability is only regional, then we cannot do only vertebroplasty. Then we'll have to supplement it with deformity correction or with pedicle screws or wires that we'll see. Now, in today's era, when it comes to surgery, surgeons nowadays are more comfortable posteriorly, and it is engaged only in patients who have got persistent pain, if there is a pseudo-arthrosis, or patients who have developed good amount of deficit or significant deformity. Now, in this case, there are some examples which I'll be showing up. So, osteoporotic bones, they are always a challenge. So, whenever you see to it, there is osteoporotic bone expected, one has to be very careful. See to it that you use the best screw, the alignment is very well maintained, the pedicles are, the screws are holding well. Also, there are screws which are like double, they have double threads. So the front part is of the cancellous thread, and towards the end is of towards the pedicle, the part which is towards the pedicle, that has cortical threads. So we can use this, and they have better grip. This is another case of osteoporotic fracture in which we have done with the normal screws, but one has to be very careful that you use additional screws. So your hold is you have more anchors, and see to that the end of the surgery the alignment is restored to normal. That's when the chances of failure of these implants that decreases. Sublaminar wires. This is another fantastic implant specifically in osteoporotic bones, because as you all know, the cancellous part has osteoporosis features earlier than the lamina. So lamina, they hold the wires goes under the lamina. So this, the chances of implant failure in such cases is actually very less. As I mentioned previously, one can do a combination of both, or even a hybrid fixation in which you do fixation with pedicle fixation with sublaminar wires. Those are also being done. The main purpose is do whatever you want, have a normal alignment, and see to it that your implant doesn't fail. Anteriorly also, these things can be addressed, but the only issue with osteoporosis is the bones are weak, so the chances of implant with an alone anterior approach, the failure of implants that increases. So one has to if doing anterior surgery, it has to be supplemented by posterior as well. And these are the cases in which, though the X-ray is looking very bad, there is good amount of kyphosis, but one has to be very careful and check out whether clinically the patient is that bad. If the patient is doing well, there's no point in doing this surgery. Okay. And I think I didn't touch on the part of teriparatide and denosumab. Somehow I missed that. Okay. So teriparatide is like parathyroid hormone, the synthetic parathyroid hormones, and it is to be given on a daily basis. The present study gives a good result for teriparatide, which can be used up to the age for 2 years in the entire lifespan. It's a daily subcutaneous injections of 20 micrograms that one has to take. Minimum that one should give this medication is for minimum 1 year and maximum 2 years. There are early stages in which more than 2 years can be given, but because of some risk of carcinogen, there are some doubts about this recent study, though they are in market. Another drug which I would like to mention is the denosumab. So denosumab is the rank inhibitor, and these medications are given. This is also an injectable form. It is given every 6 monthly, and it helps in building the bone stock well. And just like unlike teriparatide, which can be given for only 2 years in the entire lifespan, denosumab can be given for extended period, more than but every 6 months it has to be repeated. As compared to bisphosphonates, in bisphosphonates there's always a holiday phenomena which needs to be followed. By holiday phenomena, I mean you can't give it at a stretch for more than 5 years. So if you give bisphosphonates for more than 5 years at a stretch, whether it is oral form or injectable form, the bones can develop secondary fractures because of hyperactivity of the osteoclast, and we get atypical fractures. So after 5 years, one has to give a gap of minimum 6 to 9 months, and then again one can restart the drugs. Unlike bisphosphonates, denosumab doesn't need that holiday phenomena. But the thing with denosumab, it's only for 6 months. The action persists for only 6 months. So one has to take that injection every 6 months. This is, I think, is good enough. Yeah, Janki and Dr. Neeraj.
Yeah. Thank you so much, sir. Sir, as you have mentioned about the bisphosphonate, can you please let me know which one you prefer? Is it alendronate or pamidronate or something?
See, actually, so there are some studies of this Osteoporotic Society of India and even the International Osteoporosis Society, which says that there are studies which says that the effect of alendronate on reducing the vertebral fracture is quite high, okay, as compared to other agents. And because I'm more into spine, I don't deal with anything else. This formula helps me a lot, so I go for alendronate.
So that is 70 milligram weekly, sir.
Yeah, I give it 70 milligrams weekly. One has to be very careful because the bioavailability is very less. The absorption is an issue with this. So the one has to take two precautions. It has to be taken early in the morning, empty stomach, and after taking the medication, one should not have food or lie down for another 40 minutes. Why no food? Because it interferes with the absorption. And why not lie down? Because you get this dyspepsia and all this regurgitations, all those things. In patients who are taking this thyroid medications, the medication of thyroid that can be taken after some time, after an hour or so, or even one can omit on that day, because omitting this thyroid medication for a day is not going to cause any more harm, any significant harm or difference in the patient's life. So if your patient is having hypothyroid treatment going on, ask them to take this medication and avoid thyroid medication on that particular day.
And so what about additional medication like vitamin D and calcium?
Yeah, so calcium is the basic medication which we start for all osteoporotic patients. Calcium on a daily basis, it has to be given. And vitamin D. So vitamin D, if you check out in India, almost 85 to 90% of our population, they are deficient in vitamin D because we are hardly exposed to sunlight. So the formula for various formulas are present. One has to take it in 60,000 international units to be taken every weekly for a period of 8 months. And after that, take it every 15 days, maybe for a year or so, and then repeat the thing. Now, there is also, I would like to mention that there is a tendency to, as soon as take the tablets, check out your vitamin level. So it doesn't make any sense that once you have taken the tablets, it's going to be high. So there's no point in just doing the blood test along with it. Another thing about this is the recent market. There are various formulas in which they say that nanotechnology is being used. So this nanotechnology just increases the availability, the absorption of vitamin D, and that I think is much better than what formulation we have with the powder form. There are new studies which say that injectable vitamin D, that use of injectable vitamin D is now to be restricted only in patients with rickets. Okay, so earlier during my PGs, we used to give injectable forms of vitamin D. So now there's no need for doing that. There's study which show that once the injection is given, there's significant peak of the vitamin D that continues to be there for 6 months, and then it plateaus and dips down. So you never know when it's going to dip down, and you might be just deficient on vitamin D in that period. So the better formula is take it on a weekly basis for 2 months, and then put the patient on maintenance dose of every 15 days.
So
and vitamin D has to be taken with calcium, because if you don't take calcium, it's going to help you. Dietary calcium is not sufficient enough. That's why you need medications from outside.
So about the vitamin, as you mentioned, that there are some forms which is, I think few of us are advising it to take it with milk because it is a fat soluble vitamin. But there are multiple forms which is in tablet form or in syrup. So which one you prefer?
So syrup is always good actually. Because they have bioavailability, because these guys are now having this, they claim, and they show it on papers, they have this nanoparticles in that formulation. So it increases the absorption. There are various absorption gates which they have documented. So it helps. So syrup is preferable. Powder, though, I have never given. That capsule is good enough.
And so when you prefer for the conservative treatment, when you go for an operative treatment, I mean.
So what I have learned from my bosses, from my guru, is always give instability a chance. Okay, so my indication for surgery will be patient having significant pain after field conservative management. Okay, now field conservative management is like complete bed rest for 3 to 4 weeks, and then mobilization with the brace. And during this conservative management, you have to do every 3 weeks or 4 weeks, you have to do dynamic X-rays. So dynamic X-rays show whether the patient is going into union or non-union, and whether the patient is at the risk of developing deformity. And in this conservative management, along with rest, we give all these formulas: calcium, D3, and if the BMD is quite low, then even put on the patient on teriparatide. So if the patient is on conservative management, no need to do anything. Surgery is only for failed conservative management. Second, patient who present to you in the OPD with cumul sign or significant deformity, okay, or they present to you with weakness. Now, many times as retropulse fragment, they are there, but to begin with, they don't cause any weakness. But over a period of time, with repetitive micro mobility, this itself can lead to gradually slow onset or late onset weakness. So if there is significant weakness, significant deformity, the patient presents with a cumul sign, which is itself a sign of instability, the patient needs some other surgical management. Otherwise, a fresh new patient which walks in and the patient MRI is not showing like any suspicion of metastasis or other things, then always try to conserve. Interesting MRI study, I don't know which year that was, but it shows some criteria. Like on day 1 MRI, if you see, if you compare the T1 and the T2 SAG, if it's totally hyper or the otherwise, it is totally hypo, like hypointensity and hyperintensity on both. So T1 is showing hyperintensity, T2 is showing hyperintensity, or T2 is showing as well as T1 is showing hyperintensity, then the chances of that fracture vertebra going to non-union is quite high. Along with that, end plate, if it is broken, significant retropulse fragment, these are the 3-4 criteria on day 1 MRI. Like the patient has fallen, you do it the next day. So day 1 MRI, if these are the things I see, I usually advise the patient like these are the chances, and based on the study, you have got higher risk of failure of a conservative management, and that's when I advise surgery to even this day 1 patient with who come without any neurological deficit or deformity. Am I clear?
So as you, so quite clear, sir. So you have mentioned about the one sign, cumul sign, that Avinash want to know what is that.
So in cumul sign, you get this in X-ray, you get this black thing in APR as lateral view. Okay, because basically it's a sign of non-union, the osteonecrosis which is happening. It goes into non-union, and in MRI, if you see, it will represent as a white band-like thing, white fluid kind of thing in T2 sagittal images.
And so, is there anything called cumulus disease also?
Basically, it's the same thing.
Same thing. So you have mentioned about the dynamic X-ray. So that is means that flexion, normal, and extension X-ray, right now, sir?
Yeah. So anything which is done when the patient is when the spine is loaded can be called as a dynamic X-ray. So you can get it done in flexion extension, sitting prone, sitting and lying down. Interestingly, in few patients, in immediate pre-operatively, I have done this push prone view. Okay, in that the vertebra opens up very beautifully and shows us like you can actually anticipate how much it's opening pre-operatively. That will give an idea how much roughly like how much it's going to open, so you can plan for vertebroplasty or kyphoplasty in the same setting. So if it's opening up just by positioning, there's no need for kyphoplasty. If the vertebra is so porotic and it's opening up on just on prone, and you when you push it, the lateral shoot through X-ray is taken. So on position, if it's opening up significantly, then one can just manage by a normal vertebroplasty. Did not go for a kyphoplasty. That saves money for my patient. So that I have done to in some cases also.
Okay. And so, as you mentioned that in the flexion view, what all we should see, sir, in that X-ray, what to look for?
Yeah. So So all these dynamic X-rays are done to see the mobility or the collapse of vertebrae, the fracture vertebrae on loading. So whereas this loading and will lead to kyphosis at that segment. So if it is at, like, for example, the fracture is D12 vertebrae. So if you see on this loading X-rays that there is a kyphosis at that particular segment, D11 to L1, whether it is restricted to that only or there is significant toppling of D11 vertebra, is it the only D12 which is collapsing, or whether the upper vertebra are also toppling? So if that is happening, then your alone vertebroplasty is not going to help you. So if it is an intra-segment instability, your vertebroplasty, kyphoplasty is going to help you. But if it is intersegmental, or it is regional or global kyphosis that the patient is having, then alone vertebroplasty is going to fail. So that in such cases, one has to do either deformity correction or do a vertebroplasty with posterior stabilization and fusion.
Sometimes that malignancy can also present as a vertebral fracture, that osteoporotic in osteoporotic bone. So how to look for on the X-ray that it is associated with some malignancy?
So if you are lucky, then you will get this geographical pattern of destruction, like lesions on the vertebrae in metastasis. But even on MRI, one cannot be confirmed, like fully 100% bet on that this is not metastasis and this is only osteoporotic. At times it even gets confusing. But in general, metastasis, if there is metastasis, then it will be more of hypointensity on T1 and T2 both. Plus, many times this pedicle is involved or the posterior element is involved. That's more indicative of metastasis. And there are various skip lesions. So that those goes more in favor of malignancy. Also, in this pathological fracture, if you study the T1, T2 entire images, the parasag, the sagittal, many times you see that there is a fracture at one plane and the other plane there is just edematous changes that you see. So all those things point out that it's more of a malignancy. Rarely we get this significant ballooning of posterior cortex of the vertebrae, though it is not pathognomic of only being seen in malignancy. It can be seen in osteoporotic, but it's not very much commonly seen or not significant ballooning of the vertebrae that we see in osteoporotic vertebrae fractures. So pedicle involvement, posterior involvement, skip lesions, and the variegated appearance of marrow in multiple vertebrae. So that can point out towards malignancy.
So there are so many questions they have asked in the DNB. One which is very common is the type of surgeries which can be done for osteoporotic vertebral fracture. So what all they can write, sir? The DNB can write. Then what you
so depends on what the pathology is. So if there is a weakness, it just needs if it's weakness because of retropulse fragment, then just need to decompress that, fix it. Fixation can be done with either screws or wires. Okay, so regarding fixation, you can write about various modalities of fixation, like it has to be long segment. Okay, it has a long segment fixation. You can use normal screws. You can use osteoporotic screws for osteoporosis, like the DOT, double outer thread diameter screws. Fenestrated screws, in which you actually put in cement through the screws and it goes on. Around 1 to 1.5 cc cement in each screw is recommended in such cases. There's another thing in which you can do what you you inject cement and then you put in screws, but that hold is less than as compared to fenestrated screw hold. So this is one kind of thing. Then other is deformity. So in deformity correction, there are various types of correction in deformity, that either it is Pontage, Smith-Peterson osteotomy, or pedicle subtraction osteotomy. These are basically being done rarely in osteoporotic bone fractures, where there is significant kyphoscoliosis which has developed, we need to do vertebral resection and then do anterior reconstruction. But that's not very commonly done. But in significant scoliosis, rarely that can be done. So depending on what the pathologies, you can actually enumerate. The procedure remains the same. Only in osteoporosis, one has to be very careful. So for that, the screws, implants, and wires can be supplemented along with it, along with the pedicle screws. You get this even titanium bands, but the stainless steel wires, which are they actually have better grip. That's what I've been using, and at times combine them, pedicle screws with wires, like a hybrid fixation, which I've shown in one of the image.
And so you have mentioned in your lecture that one is screw, which is the proximal part is cortical and then other part is cancellous. So is it for the better grip, sir, or what is the advantage of?
The advantage is the cancellous part, which is the body. It has the thread is at the width of the thread is pitch. The pitch is actually larger, and it decreases as you come towards the cortical side. So like machine screw or the cortical screw, the threads are like a cortical screw, very close by. So that actually helps. And I don't know, I have that image on my mobile, but not on the laptop. So otherwise, I would have shown you.
And so just one related question of that one, sir, that when you put the screw in osteoporotic bone, you are directing it towards the anterior cortex, or just to touch the screw or to cross it, that is better?
So I don't know whether you can see this. To increase the grip of the screws, okay, so one has to always be convergent, use larger diameter, larger screw, longer screw, larger diameter, convergent, and even on the same side, one can be directed, it can be directed the inferior, one is directed inferior, the other is directed superiorly. So that can be done, okay, just to increase the grip of the thing.
So in both the plane, it is
and even couple of millimeters, if you take a bicortical purchase, like how we do in sacrum, this can be done in osteoporotic. Many times I actually do that in osteoporotic bones.
And what about in the fractured vertebra, sir? Do you put the screw in that one also?
So index vertebral fracture I do only if I supplement. Most of the times I don't do it, because many times you have to do a subtraction osteotomy or some kind of osteotomy in that vertebrae. But if you are doing a vertebroplasty in that level and fixing at the same time, then cement from one end and pedicle screw from the other. That's what many times I've done that.
And so the difference between the vertebroplasty and kyphoplasty, is it in the balloon only, or in the type of cements, or anything else, if they can remember, sir, for the difference?
Cement, anything you can put, the same cement you can put in both, but this is not the cement that we use for the normal hip and knee cases. So this has to be the polymer size is difference, okay, and cement can be the same cement can be used in both. The difference is the principle. In kyphoplasty, you actually recreate the height by the pressure from within the vertebrae. So what that happens is all these bones fragments, they actually go on the sideways and they get aligned to each other, and that creates a hollow kind of thing. Then once you have done that, you deflate the balloon and you pull it out. So now the cavity is recreated, the height is restored, and then you put the cement. So this is an entirely different thing as compared to what vertebroplasty is. In vertebroplasty, you just make the patient prone, whatever it opens, you just put in cement. So you are not going to increase the height. You are not going to the bones which are there scattered, particles which are scattered. You are not going to do anything to it. But if you do this balloon vertebroplasty by pressure, it inflates by pressure, which it gets a contained cavity. So the chances of cement leakage minimizes in kyphoplasty. The chance of restoration of the height increases. The chances of getting normal alignment, that increases. Okay, of course, there is a price to that. It's expensive.
Yes, sir. Other than the price, if as you mentioned, most of the thing is the benefit of the kyphoplasty over the vertebroplasty. Is there any other benefit of vertebroplasty over kyphoplasty, sir? Other than cost? Or is it
less time consuming? Nothing else.
okay, sir. And so usually how much cement is required when you put for vertebroplasty?
2 to 5 cc is good enough. If you go beyond 6, then that's the time you can even have fracture of the upper vertebrae. So anywhere between 2 to 4, 5 is good enough.
So is it possible to do the multiple vertebroplasty in a similar sitting?
Yeah, it can be done. Specifically in this metastasis patients, where there's question of instability and the patient is unfit, then this can be done. In fact, even in our setting, we have done vertebroplasty under local mild sedation. If the patient is unfit, we can do that.
Okay, that with the Jamshidi needle, as you mentioned, sir. Okay, sir.
Sorry?
And with Jamshidi needle, as you mentioned.
Jamshidi needle.
Okay, sir. And sir, is there any criteria for prophylactic fixation when you are having when you are suspecting that it is going to fracture?
It's going to fracture, prophylactic.
Yeah, prophylactic fixation like we used to do in the malignancy, like one criteria like Miral's criteria when.
Yeah. So I avoid all those things, and as far as the malignancy is considered, I consider malignancy patients, cancer patient, as a patient of oncologist or oncosurgeons, and my role as a spine surgeon is a very limited role whenever they call me. So my role as a spine surgeon in onco patients will be only for neurological deficit and proven instability. Because many times this which appears in unstable with radiotherapy, within few weeks, the bones get sclerotic. There's no need for fixation. I've seen enough. Even some doctor's father, I have seen that. Myeloma patients specifically. So that can be avoided. Prophylactic fixation can be avoided with medication, with proper treatment. I don't say don't do anything, don't operate, but there are other modalities like radiation and chemotherapy. Even the sclerotic agent, denosumab. So denosumab, even in GCTs.
I think sir will join in 1 or 2 minutes because of his battery. In between, if you have any question, like as you asked about the bisphosphonate, it is already done. That the dose is 70, as sir mentioned. Sir, you are able to hear?
All the bisphosphonate are using 70 mg, sir.
Hello?
Yes, sir. Sir, Sumit has asked the same question about the bisphosphonate dose and use, as you mentioned that 70 milligrams.
So bisphosphonates, the one which I use oral bisphosphonates is alendronate, 70 milligram weekly. Maximum you can give is continuously is up to 5 years. And after that, you need to give it a break.
Yes, sir.
And so about the breast, because it is quite common fracture, we used to see lots of patients with osteoporotic fracture, multiple osteoporotic fracture, and usually they are provided with the brace. So which type of brace you prefer? Because sometimes I have seen someone used to give the tailor, someone give the anterior brace. So which one is ideal for the thoracolumbar or osteoporotic vertebral fracture?
So this hyperextension brace is very ideal. Okay, the principle wise. But what it does is it leads to very discomfort, adds to the discomfort of the patient. So if the patient is having discomfort and not going to use it, then I think tailor's brace is something which actually is more beneficial because it has better compliance amongst the patient. So I usually go for this tailor's brace.
Okay. And so if the patient is having that vertebral fracture and after the brace, what you are the other advice you give, like how much time in for the laying down position, or when he can sit up, how to sit up?
So once the patient, you mean the conservative management, how the details of the conservative management. So basically complete bed rest, and depending on the pain, the patient can be mobilized. So it's a very minimal fracture just along the superior end plate, and the patient is comfortable at the end of say 2 weeks. There's no need to keep the patient in bed for another 3 weeks, 4 weeks. So 4 weeks is ideal time, and if in some cases extend it to another 2 weeks. And whenever you mobilize the patient, you mobilize with the brace. A brace is not something like a magic wand or something like that. It's just something which will avoid additional jerk, okay, and just be there as a reminder to the patient that they have to avoid certain jerks, certain activities, at the same time support to some extent. Once the patient is relatively pain-free, start with exercises. Even in bed when they are in pain, one can actually do the isometric exercises, and once relatively pain-free, then start with strengthening exercises, back strengthening exercises.
And so just one more question about, as you mentioned about the long segment fixation, long posterior segment fixation used to prefer over the short segment. So if it is an isolated vertebral fracture, in that case, is it preferable to go for long segment fixation, sir, or short segment? Or how do you decide about that?
See, unlike in young bones, young people, when there is a fracture, we tend to have a shorter segment. The strength of the bone is quite good, so the chances of pullout is quite less. Screw pullout is quite less. So in osteoporosis, always have a longer segment. And here we don't plan to do just fixation. We always plan to do fixation with fusion. So that if you increase the fusion bed, if you increase the number of screws that you use, the anchor's point is increased, the chances of failure going into kyphosis is less. So why it fails? Because most of the times with the senior population, there is a tendency to bend forward. So that's what is normally happening. As with the age, even those who don't have fracture, even gradually they have a tendency to kyphose forward. So with a small segment, just one above, one below, the chances of failure of that construct is quite high as compared to a longer construct. Like in one of the patient which I have shown, I have used 3 vertebrae above and 3 below. That is 6 screw above, 6 below. And that was purely osteoporotic fracture. The patient had been in bed for almost more than 12 months. After a year, she got convinced, no, I have done with all this conservative management, I can't do without surgery. That's the time she got convinced for surgery. So once the patient is bedridden, decreased activity, the chances of osteoporosis, then hypoplasia of the muscles, then the failure of the posterior tension band, that is always higher. And to negate that, you need longer segment fixation.
And so what is the treatment of screw pullout if it is like pedicle screw which is backing out? In that case, used.
So always that X-ray has to be correlated with the clinical phenomena, clinical symptoms. So just screw pull out, but the patient is comfortable, don't do anything. Brace, continue with our medications, teriparatide, denosumab, or osteoclast like bisphosphonates. Wait for some time, have a regular follow-up. If the patient is in significant pain, yes, you need to revise that. And when you revise that, you need to have better screws. So that might be DOD screws or hydroxyapatite coated screws and fenestrated cement with cement screws, or you can go for heart shape. So your implant has to be different than what it was before. So or the same thing, you have to extend it. But before you jump onto it, you have to take care of 2 things. One is how badly the patient is symptomatic. And note there, why did the implants fail in first place? So is it the bones were so porotic that it failed? So in that case, why not to wait for some time? Give teriparatide for another 6 weeks, 6 months. wait, hold on till you pull on till you can, and then operate? Or is it because of faulty technique, faulty screws, or faulty their screws are not in position? So always take into consideration both the things: one, the patient symptoms, and the cause of the failure. And based on that, you make a decision whether you need to go in or you can avoid going in. And if you have to go in, what else can be done?
And so, what about the interior fixation? Do you use that one?
Honestly, I have never done that for an osteoporotic fracture.
And so, what is your thinking about salmon calcitonin for the?
Yeah, so when this drug came into the market, it was more believed that it's bone building molecule, but eventually it on subsequent DMD studies, which was done in placebo pre and post calcitonin studies, they found that the only role it has is to relieve the osteoporotic pain, the pain because of osteoporotic fracture. And that's why its now role is not for treatment of osteoporosis. It is only for the treatment of pain because of osteoporotic fracture. So that typically lasts for first 1 month or maybe 1.5 months. So the role of calcitonin spray is just for first 4 or maximum 6 weeks of a fresh osteoporotic or acute osteoporotic fracture. Only for pain relief, not for it doesn't cause increase in osteoblastic or increase in osteoclastic activity. So it's not for bone building or increasing the bone strength.
So that is for one dose, like that one ampule is
So
one puff in one nostril.
One puff daily in nostril. So you alternate the nostrils. You have only 2 nostrils, one nose and 2 nostrils. Okay. So alternate nostrils, you take one puff daily. And because it's a hormone, so all these hormones preparation, they have to be the temperature has to be well maintained. Okay. So whenever you open that sample, see, it has to be in refrigerator. Whether it is any teriparatide, denosumab, or calcitonin, you just keep in mind. Many times it's lying outside, it may or may not be that effective.
So not in the freezer, sir, in the refrigerator outside. Yeah.
No, not in the freezer.
Most of the thing we have covered, sir, and it was very well discussed. Today, our chairman, Dr. John Mukhopadhyay, sir, was not able to join this one. So I think we have covered most of the thing, and we are very thankful to you for describing it and so simplify it well for our postgraduates. So thank you so much, sir.
Thank you, Dr. Janki and Ortho TV for this opportunity. Thank you. And John, we are missing him.
And I think DNB exam is starting from tomorrow. So all the best for all the DNBs is exam going.
Yeah,
okay. Thank you, sir.